First, begin by thanking Moss Adams for inviting us here today. Disruption, innovation, transformation are three great topics within the healthcare arena, and particularly so, I think, in the behavioral healthcare arena. We've heard a lot of common themes through many of the speakers today that I think will be further weaving into our discussion. And frankly, we've been tasked with discussing how behavioral health has changed over time and some of the disruptions that are happening in the system today that will lead to further transformational changes. And I believe we have an excellent panel to do so. So I'm going to briefly introduce everybody here, and we'll get started. So first in the middle, we've got Brandon Staglin. Brandon is the president and the founder of One Mind. One Mind is focused on biomedical research and is looking for ways to combat traumatic brain injuries and serious mental illnesses, depression, schizophrenia, etc. Also to his left, we've got Dr. Nitin Nanda. He is the CEO of Aligned Telehealth. Aligned Telehealth is one of the pioneers in behavioral health physician support via telehealth, and we've heard a little bit about that. We'll go into that in more detail. All the way on the end there is Patrick Connell. He is wearing many hats. He is the VP of Behavioral Health, Compliance and Government Relations at Boys Town National Research Hospital. Boys Town is focused on improving the lives of children suffering from abuse, addiction, abandonment, and violence, and he brings great perspective to the table. And we've also got the rose between four thorns here, Patricia Blum. She is the Executive Vice President of Crestwood Behavioral Health, one of California's leading providers of mental health services, I believe, all over the state. So again, I think we've got a great panel of experts with some amazing experience here and some insights, and we'll get started. So I wanted to start briefly, since I don't get to talk the whole time, providing an environmental overview. And I know you've all heard some of this today, but I think it's important to help frame our discussion. It's 10 years ago this year that the parity in mental health parity laws were passed, and I think anybody who's involved in this industry would argue that we still have significant challenges associated with reaching true parity. But that has clearly raised awareness of the many issues associated with behavioral health, and we will continue along that line. We've also are now well into the implementation of the ACA, which was frankly the broadest expansion of access to care and particularly behavioral health services in many, many decades. In fact, in this last election now, we now have what looks like another 5 states that will be stepping forward to expand their Medicaid programs. And again, a huge component of that expansion results in better access to behavioral health treatment. So we look forward to that. We've also had the twin epidemics. I know you've heard a lot of talk about opioids and the last panel talking about opioids. But we also have an unbelievably high suicide rate in this country, pointing to the need for additional services. And I'd also point out that in addition to the 70,000 plus individuals who die of opioids from opioids annually, we have an even higher amount of individuals who die as a result of other SUDs, be it alcohol, cocaine, methamphetamine, and others. So this is a huge and ongoing problem, and while opioids have really helped to highlight some of the critical issues facing the country, there are broader other SUDs and mental health needs out there that need to be addressed. We do have some positive developments on that front. We had the Cures Act, which was enacted a few years ago and provided a huge infusion of cash to the states to begin addressing the opioid crisis. The last Congress just passed recently in October, as was mentioned earlier by another panelist, the Support for Patients and Communities Act. That is providing another infusion of cash across a wide variety of initiatives, including for the first time since the 70s, a partial repeal of the IMD exclusion under the Medicaid program, which frankly is a relic of a past time that prohibits the actual, the people who are most in need of behavioral and substance use services from accessing treatment from the experts that exist out there today. So very pleased to see that. In fact, we'll talk about that a little bit later as well. But just this week, the administration released a new letter to the state Medicaid directors, also expanding access to IMD treatment. So that's another positive development. We also had in the last Congress a Family First Act that was passed dealing with services for children and adolescents, recognizing the needs that are faced there, that has some problematic aspects to it that we'll get into. And finally, obviously we've heard again some of from the criminal justice system and some of the issues associated with individuals there. Frankly, in many areas of the country, the criminal justice system is the largest provider of mental health services in the area, which quite frankly is frightening. But I think combined, all of these dynamics together have led to a growing recognition of the fact that behavioral health should be an integral part of overall health. And I think we're going to focus our comments today at kind of the areas that need to be disrupted and transformed, and those are and improved, and those involve access, coordination, integration, and payment. So across the board, there's some good work to be done, and I think, as I mentioned, we've got some experts here that really are on the forefront of this. So to kick this off and bring in the panelists, we've broken it out into several issue areas, and we're going to start with advances in brain research. And I want to invite Brandon to start the conversation. He has been actively involved in research on brain stimulation and its potential impact on treatment. And I'd like you to just share with the audience some of the findings that you have.
Thank you, Shawn. Yeah, so there's a lot of hope to be gleaned from the research going on today in neuroscience. And we at One Mind believe that all people who experience brain health challenges should not just survive, but thrive. So one aspect of thriving in life is the ability to adapt to new situations, to solve problems in unique and creative ways. But many people who experience brain health challenges like, say, depression or autism or schizophrenia have challenges with mental flexibility, the ability to do these things. For example, people with autism might not be able to adapt easily to new routines, or people with depression might not be able to easily break out of pessimistic thought patterns. These are just two examples. What if you could actually address that mental inflexibility with a neurostimulation-based treatment that could be applicable across a wide variety of brain health conditions, right? So Dr. Alec Widge is a One Mind Janssen Rising Star Award winner from 2017, and he is at the University of Minnesota. We just heard from three great people from Minnesota. And he is doing research on how to stimulate the brain to improve mental flexibility. So what he's done is he's found that in both humans and in mice, if you use a certain rhythm of electrical stimulation in deep brain stimulation, like with an electrode implanted in the brain, you can improve people's ability to solve problems in new ways. So what he'd like to do now is, because this is reproduced in mice, pinpoint the exact circuits in the brain that are involved in this process of mental flexibility, so that the treatment can be delivered not by an electrode implanted in the brain, which is not very scalable and easy to do, but via things like transcranial magnetic stimulation, which is delivered by electrodes placed on the head, or focused ultrasound, which is sound waves projected into the skull via speakers on the top and side of the head. So if you could pinpoint these actual circuits in the brain through the mouse studies, that's what he plans to do, then we can actually have this mode of treatment available for lots of people around the United States and the world to address their challenges with mental flexibility. And this could be a great watershed for people involved who experience brain health challenges.
I know, Pat, you also at Boys Town have an NIMH lab that has been involved in doing some work on identifying markers for mental health to identify up front potential issues.
So about 12 to 15 years ago, Tom Enso, who was then the director of the National Institute of Mental Health, invited a group of researchers and research organizations to come back east. And he challenged the researchers to begin looking for biological reasons for mental health as part of a broader focus on research. And with that kind of raised some issues for us, because in our behavioral health programs, we think about 85% of our kids are successful. But what about the other 15%? Is it the treatment wasn't effective? Is it there was a biological reason why the treatment wasn't effective? Is it the environment, et cetera? And so we went to NIMH and had some discussions about how we should look at this problem for children and adolescents. And we had some researchers who were very interested, Dr. James Blair, who was using functional MRI in mental health at that time. We invited him to come to Nebraska, and he brought a team with him. They all moved to Nebraska, and they're starting to see some interesting results, being able to identify, for instance, early biomarkers for conduct disorders, oppositionally defiant disorders. But one of the other, and there's a couple of other areas that we're very interested in, one is children that come in on drugs, whether it's illegal drugs or psychotropic medications. We've had 500 children that have came in on more than 5 psychotropic medications. That's a lot for children, and especially as a lot of these medications are done off-label. So what is the long-term effect of those kind of medications? And so Boys Town has a study where we follow the children that are discharged from our programs 1 year, 5 years, 10, 15, 20, up to 40 years after discharge to see how they progressed in life. But the other thing is that we're also looking at can you use functional MRIs to evaluate whether or not treatment is effective, and how is treatment effective? How do you measure that? What are the markers that will help you determine? And we're hoping that this opens up a new area of research, but also a new area for treatment effectiveness, measuring treatment effectiveness.
I think that historically has been one of the problems in the mental health arena. Unlike physical health, we don't have a bad knee or the bad shoulder or the back or the heart valve or the other tests that exist to be able to say this is definitively what's going on, this is the diagnosis, and this is how this is a treatment plan to move forward. So some exciting things happening in these areas. Patty, do you want to talk a little bit about brain plasticity and what your experience has been at Crestwood's and finding about things the brain can do to heal itself?
Sure. So one of the interesting things about what I bring is probably in contrast to the rest is having done the services, our organization are really providers. And we provide the services to some of the folks with the most significant challenges. When we talked this morning about the 5%, we work with the folks who are probably in the top 3% of our population, and behavioral health spend are about the 60% of the spend in behavioral health. They're the folks who have the highest level of recidivism and probably truly the highest rate of failure. So in the concept of transformation, I feel like in behavioral health for the past 40 years, we've heard about transformation, but I love the disruption. I love the idea that we're changing something because it has to be changed. So as we looked at what we've done, and we've been doing this for a very long time, really with the genesis of folks getting discharged from state hospitals, we became providers of that level of care of those sorts of folks, and we had to change what we do to make it be successful. And what we would see is we'd see some success and then challenges. And we'd see people with, we track people for a year or two and we'd see the low recidivism rate, but then at 26, 30 months, they're back in the system again, and frequently with stumbling at a much lower area. So we looked to see what we could do really to take science to practice, but also to take practice to science. And we worked with SAMHSA in their trauma-informed area, trauma-informed center at SAMHSA, and we started to look at what's traditionally used for folks with significant mental health issues, and especially folks who are continuously being traumatized, to what we could do differently. And one of the areas that we found the most success, and we're really gaining some traction, and we're having Yale and Rutgers which is sort of focused in on creating some research projects for us to do to be able to bring this into evidence, is working with the somatic experience of trauma and really looking at ways that we can teach people skills to change their story neurologically, to reframe their brain so that it goes from a story of symptomology, and it goes from victimization to a story of success and resilience. And so a lot of what we do is the somatic experience in the trauma, and that's kind of from our perspective. We have a few different things that we do, but that would be the one of really taking science, bringing it to practice, and then bring it back to science and say, let's build up the evidence to demonstrate the success.
And just to wrap up this area on brain research, if Brandon, we talked a little bit about neurochemistry and some of the things that you're seeing there.
Yeah, indeed. So in response to something you said a minute ago, we don't have biological markers for brain illness or mental illness. We're actually developing those now. So depression has been challenging to diagnose in an accurate way, in a precise way, because there's so many potential causes for major depressive disorder. It could be due to a genetic predisposition. It could be due to chronic stress or trauma in someone's early life. So if there was a biological way to diagnose depression, then you wouldn't know, you have a better chance of knowing the cause and addressing the cause with biological treatments, like medications, for example. So what a scientist named Dr. Ian Mays at Mount Sinai School of Medicine, one mind funded in 2017 with another Rising Star Award, is doing, he is developing a blood test for depression. Now, this blood test functions by the fact that there's a histone, which is kind of protein in the brain and also in the blood, that acts in the same way when someone is depressed in both places. So it's modified by serotonin, which you may be familiar with as a neurotransmitter that is involved in treatment by medications like Prozac or Paxil. So he's been able to find that in humans and also in mice, that as someone gets more depressed or a mouse exhibits symptoms that mirror depression, this level of this protein in the blood changes, actually goes up. So based on this, he's working with humans and mice to validate this protein as a biological marker for major depressive disorder. But not only can it do that, he anticipates it'll also be able to, because of its relationship to serotonin, be a predictor of whether somebody would be helped by SSRI medications, they're selective serotonin reuptake inhibitors, thus saving weeks of trial and error. If many people are diagnosed with depression, they try different medications for weeks and weeks, perhaps months. They might not ever find one that works for them. This would save them all that time to know whether or not that medication could help them. In addition, it can tell whether somebody's at risk for depression and under chronic stress, which could help people kind of plan for their future life. If they're going to take on a stressful job, you can make sure they have a strong support network in place to make sure they're healthy. It can also reduce stigma by knowing that there's a biological factor behind somebody's quote-unquote mental illness. It proves that it's not all in your head. It's not your fault. It's a moral failure. And so it's a physical illness just like any other medical condition, as it ought to be viewed, because it is. So all these great outcomes can come from success in this research, and I'm really excited about it.
So one of the other areas that we wanted to focus on following research is the use of technology. Obviously, Americans are very innovative in this area of new technologies and digital tools that are starting to come online that are actually now starting to have an actual impact on patient care. And taking some of this basic science and moving it into actual technologies that can be used for patient care. And Nitin, I wanted to bring you in and talk about your digital platform and some of the things that you're doing with Align Telehealth and its role in really starting to normalize mental health services.
Great. Well, thank you, Shawn. Great to be on the panel, this team panel here, and great to be with you guys. So I'm a geriatric psychiatrist by training, so as I hear about biomarkers and so on, I'm at UCLA. So we've done a lot of work, of course, with dementia, especially Alzheimer's, functional imaging, and so on and so forth. We're very small. So I run a company that I founded, Align Telehealth. We're the country lead in telepsychiatry. We use different subspecialty psychiatrists, child adolescent docs, adult, geriatric, forensic, mid-levels, and we provide a profoundly disruptive service in the emergency rooms. So we basically provide 24/7 care. And this really mushroomed out of my geriatric practice over 20 years. When I realized when I went across state lines to expand my hospital's practice, I really couldn't find docs. So I started Skyping originally, and I told the hospital, listen, your critical access hospital, your patients that need to be seen, the highest number of suicide patients are coming here, the indigent or unfunded, you are it, you're the primary care point for them. And that's really how it started in New Mexico from California. And that is now mushroomed into a 20-state operation where we work primarily with enterprise-level hospital systems, critical access hospitals, post-acute, and provide 24/7 coverage in emergency rooms. We have a beam in time from the time a consult is called to seeing a patient at a bedside at 42 minutes nationally, which is a bit different for our specialty because a lot of the docs who go in our psychiatry specialty like not to do too much of the medicine work. They like to go to bed in time and do their therapy and management. So it's been great to bring in a whole new wave of graduating psychiatrists who are treating this more of a nuance and new science, so to say. With this, we've also been able to address the huge shortage of psychiatrists. I think next 3 to 5 years, you're going to see them shrinking by about 40% more. So we have basically been able to bring in virtual care where boarding time in the ER's national average is anywhere between 8 to 11 hours. And that's mostly in urban areas. Critical access, rural areas, you can just forget about it. So what we've done is essentially provided them with robotic units, virtual care, where docs are sitting in a distant site and they go live through a really good process we put together and be able to see the patients on bedside for full evaluation. And thanks to EHR, we are able to do everything, or EMR, we're able to do everything virtually, including prescribing. And so the digital platform we put together is a full end-to-end solution. So it's not just the clinical services as a physician group, but it also has everything built into it. May that be the scheduling app, a call center, an EHR that you can use, a business intelligence dashboard where you can see metrics, a quality metric built into it as well. And so that becomes a fully encapsulated plan in which we're able to deliver this. And we had to develop it over time because seeing a patient on telehealth is one thing, but then to be able to fax things over didn't really work well for us. So we built this whole portal and a platform with which we can deliver services. We've been very disruptive. We've been able to reduce recidivism, repeat admissions to ERs, reduce overall transfers to acute hospitals, and been able to bring down the crisis that you would see in the ERs. May that be the suicides, whatnot. I mean, if you realize, 1 in 2 patients who commit suicide has been seen in an emergency room in the last 60 days. And so we've been able to address a lot of that. Interestingly, we've been able to address a lot of the needs for the child adolescent patients who are sitting there in the ER. And a lot of the docs are gun shy of being able to see them do a consult, so we can bring a child adolescent psychiatrist who can then beam in, be with the ER docs, and do a consultation with them. We then follow those patients also to the medical floors, and if need be, provide coverage to the inpatient units as well. And that's been extremely successful for us across the board. And again, it's like I said, it's turnkey.
Thank you. Pat, I think you have some experience as well with the use of electronic health records and electronic prescribing. And how has that technology really helped improve your services at Boys Town?
The first thing I'd like to comment on is that we serve kids from 38 states, and we've had them from 8 countries. And typically those kids that are coming from other states and other country are being referred to us because of the severity of their mental health problems. And with that, on average, we have 3.4 failures, meaning that the child has been in 3.4 either treatment programs or placements unsuccessfully in the last 18 months prior to them coming to us. So the NIMH researchers thought that that was very interesting, and that's what kind of attracted them to us. And they started asking questions that sometimes we could get out of the electronic health records, and sometimes we couldn't. But what became really clear to us is that the traditional electronic health record is designed for episodic care. In other words, for an inpatient hospitalization, a series of outpatient visits, and the data did not flow between the two systems. So we've started an initiative in which the data collection is from the time we get the initial referral through the treatment programs they are with us at Boys Town, and then is tagged into what we collect after the discharge. And what we started seeing from that was, when these children come in on high doses of medications, it's easier to identify trends within practitioners as far as how do they reduce those medications, how long do they take to reduce those medications, and then what medications that they prescribed afterwards. And that has turned into a very interesting discussion with our child psychiatrists, because it's provided them with a forum to learn from each other. And it also starts making them acutely aware of their prescribing habits for psychotropic medications. And we see the electronic health record having to branch out to collect all this information across care platforms in order to really be effective for program evaluation and then also for research.
Unfortunately, the behavioral health industry was more or less excluded from the move to the adoption of the electronic health records. They did not receive the same level of funding that the med-surg side of the equation did. So anything we can do on that front, I think, to help expand the adoption of that. Obviously, you have adopted it as an effective tool, even without the dedicated revenue from the federal government. And it's interesting that both of you mentioned about the effectiveness of treatments associated with that. Brandon, I believe you've also got some research that you've done on how do you measure effectiveness of treatment?
Yes. So One Mind is involved in a new initiative which we call ASPIRE. It stands for Applications for Serious Psychiatric Illness Recovery, and it's involving serious psychiatric illness in young people. Basically, psychotic illness devastates individuals and families and costs the United States over $156 billion annually in healthcare and indirect costs. I have experienced psychosis myself. I was diagnosed with schizophrenia in 1990 when I was 18. And I have no doubt that without early comprehensive intervention, I would have ended up either disabled or homeless or in jail or dead by suicide. Fortunately, I had a supportive family and quality medical care early, and I also stayed involved in the community during my early recovery. So this has given me a passion to help a new model of care for early psychotic illness called coordinated specialty care, which is being deployed around the United States at a pretty good rate already, but it only serves about 8% of the youth who need it. About 100,000 young people a year develop psychotic illness. And only about 8% of those can access this form of care currently. So what our ASPIRE program at One Mind aims to do is to increase this number to 75% by 2040 and increase the percent who recovered from 22% to 75% by 2040. Yes, this is ambitious, but I like stretch goals. So basically, we're working to not only expand coordinated specialty care throughout the U.S., but also merge these programs into a learning healthcare network so they all collect data on their outcomes and the efficacy of their treatment and the cost effectiveness of their treatment, so they can compare between the different programs in different places that are doing this and enable each center to share their strengths with the other centers and all a rising tide to lift all boats. So this will improve the quality of care, the cost effectiveness of care throughout the United States of coordinated specialty care, and will enable more young people to recover. On top of that, we're also aiming to pilot innovative diagnostics and treatments among this network in a research type setting to make the care even more deeply beneficial. So they say it's better to light a candle than to curse the darkness, and I hope this ASPIRE program will light millions of candles.
Thank you. In the tail end of last year, The FDA approved for the first time marketing of first mobile apps for substance use disorder treatment. We've subsequently seen a virtual explosion of chatbots, other symptom trackers, a wide variety of applications that are available both to clinicians and to patients. Interested in the whole panel's view on really some of those new apps, so to speak, on their effectiveness. Are you utilizing them within your programs? And are you seeing uptake, effective use of them? Are they helpful? What are you seeing across the board? I'll open it up to all of you.
Well, I can start. One of the things that we've done is the folks who we work with, again, are the most disenfranchised. And so technology has to be very accessible. And actually, to go back to the couple of points as I was listening, when Pat was talking about the EHR system, and use of that we have found, we've tracked outcomes since probably 1998. Use of our EHR system has really been transformational in looking at outcomes post-discharge as well. So it's really one of those areas there are a lot of benefits that we had no idea we were going to embrace. The other is what Brandon was saying with regards to, again, disruption and where it fits in with the applications, is that stigma continues to be the greatest barrier to service. And so the more that we can do to destigmatize mental health issues, the more that we will do to save lives. And apps are one of those things. There's not, even the folks who we work with who we do some homeless outreach, most people have a phone and are able to access an app. And one of the apps that we've seen that's been super effective, particularly with millennials, is an app called iChill. And it's very simple, but it's skill-based, and it also is a symptom tracker. So you don't have to use your symptom tracker. You could still get the skill-based information, but they also track symptoms. And when they've got 3 different, UCLA's one of the institutions, but across the country, 3 different research projects are looking at that. And so there's the sorts of things that anyone can access post-treatment, whether they're homeless or whether they're, able to be employed in a home.
That sounds tremendous. I'm so glad you're using that app. So I used an app when I was recovering from schizophrenia back in the mid-1990s. It was called Fast Forward, but it's evolved into another app for brain training, cognitive training for schizophrenia, or anyone can download it from the App Store and use it. It was a turning point in my recovery to be a part of the clinical trial that I participated in to do this cognitive training. It involves training the brain to strengthen its neural pathways in ways that are conducive to better paying attention, better focus and working memory, so you can remember what's being said and be more fluent in conversation. I had all these effects from that cognitive training. And so it's similar to what you were describing with the neuroplasticity. But that's turned me into a proponent of digital health. And so one of the programs that OneMind offers today is something you can all look at if you like. Maybe would help you in either people you know with mental health conditions, or if you're a clinician prescribing apps or letting people know about apps. It's called Cyber Guide. It's spelled PSYBERGUIDE, and then it's .org. It's a website that rates and reviews mental health apps. And there's about over 10,000 mental health apps that are on the market today, and many of them may not be effective, or may not have a research base behind them. So what CyberGuide does is evaluates the research base, the privacy and security policies of the app, and also the user-friendliness of the app. And so it's got about 180 different apps rated and reviewed currently. It's a very useful resource, I think. So check it out if you're interested in mental health apps.
And that's one of the challenges that providers have, which is there's thousands of these apps, and how do we figure out which apps are treatment effective, and for what target population are they best suited for, and then how do you figure out how to use that within your treatment program? And we have at NABH, we have these annual meetings and semi-annual meetings, and it's kind of a conversation, an ongoing conversation topic. How do you figure out which apps work? And then how do you use them, and are they effective? And I got to say, for the vast majority of providers out there, it's like looking in the telephone book, trying to pick on the yellow pages, trying to pick out what they think might be the one that works for their patient.
And I'll pick up from there, Pat. Being on the provider side of things, we got about 140 docs of work any given time within the network of Aligned. One of the challenges we were having was if we have a queue of patients that need to be seen in hospital A, hospital B, hospital C, one sitting in Montana, one sitting in Indiana, one sitting in Arizona, how do we coordinate all that? So my call centers were having these wires crossed all the time. So we developed an internal app, and we call it a scheduling app for Aligned, which every doc has on their iPads, phones. And so it queues you in, and it queues, hey, doc, you're second in line, 3 patients waiting, and you just press a button there to say, hey, go on to the next backup doctor on call. So to your point, we researched it. We looked at a lot of off-the-shelf solutions, couldn't find anything, so we had to customize it to what we needed. Similar thing happened when we created a billing app right in there for that as well. So there are apps which are for consumers, the apps which are for the provider base, and they have to be able to work in sync. And I think as you see a lot of telemodels being launched between direct to consumer, you're going to see a lot of those coming out. I think if you're with any of the major peers, they offer those to you now, whether that be Teladoc or American Well, you have those now available to you through the apps. So evolving science in a lot of ways, and you're right, a lot of them out there. I think you just got to be able to pick up one and customize it to what your particular needs would be.
Before we leave the technology section of our discussion, just earlier in November, on the 2nd of November, we're bringing another federal agency that's stepping into the fray here and looking to improve behavioral health services. CMS actually announced a final rule expanding payment for telehealth services for both mental health and SUD. A dramatic expansion, but I think I'll leave it to our telehealth expert to let us know what you think the impact of this could be.
Fresh breath air. So yes, there's been expansion and finally some reimbursement. What's been interesting is so far what we did on the tele side was really between our group and the hospital, but now we're getting subsidies somewhere. So with the expansion and all these GD modified codes coming in, they have expanded the codes in mental health to not just medication management now, but also crisis management and psychotherapy. There's still a lot of legislative challenges and issues on the regions and geographical challenges. You still have to be a healthcare professional shortage area to be able to get reimbursed by CMS or Medicaid, Medicare. But a lot of other expansion has embedded now monies into the ACOs, to IPAs, and so you can basically have capitated model in which telehealth will be reimbursed for Medicare Advantage plans for that matter. But now we do have new codes that have come in, and a lot of them are in fact psychotherapy codes, which will be available to us. And across the continuum, may that be in the ED, may that be emergency hospital settings, critical access, or post-acute, and also on the ambulatory side, where some incentives are based not just for getting reimbursed fee-for-service, but also the clinic and the hospital get a facility fee with it. So to incentivize them to use this as a module for treatment.
Well, I know that typically the private sector will follow what the Medicare program does. What's your experience with managed care plans currently, or the employer-provided plans and their adoption of and payment for telehealth services?
So we've had some good success with them, surprisingly so. We went in, we did the billing, and we were getting reimbursed. So there has been more and more, especially like I mentioned earlier, the ACO side, Medicaid Advantage plans are now reimbursing for telepsychiatry services. And these are in the primary care settings, in the ambulatory side.
One of the other areas, completely different payer. We mentioned earlier that in many areas the largest behavioral health provider in the area may be the criminal justice system, the local jails. What are they doing? Are they? I understand that they are adopting some use of telemedicine as well. Is that your experience?
Yes. So Align does provide services to county jails and prisons. Those are, like I said, I think one of the largest mental health facilities now. Almost 30% of inmates coming in at any given time are chronic mentally ill or SMI population or substance use.
Not to interrupt, but I would argue they're not really providers of mental health services. They are essentially new asylums. They are housing individuals and not necessarily providing them the services that they need, both on the mental health side and the SUD side.
Absolutely. And having been on the provider side, we see the torment they go through, apart from just for being in there incarcerated, but also having the mental illness on top of that and an overlay to it. So telepsychiatry, telepsych services, telehealth becomes an amazing conduit to be able to reach out to them and provide medication management, crisis stabilization, and therapy as needed. And typically the reimbursement for us comes from either the county or the federal government for that.
Pat, you've had some experience with this as well?
I was going to add to this. We have a detention center that we do provide telepsychiatry services as a pilot, and that's mainly for doing evaluations for the court for children that are going to be adjudicated, and then also looking at the type of medications that the child comes in on and as whether or not that is appropriate for that child. I think, though, that the thing that telehealth is going to have the greatest impact on in the future is increasing the access to in child psychiatry and child mental health is for the rural areas in the frontier parts of this country. There's such a shortage, and these mental health professionals want to live in an area where there's a population so they can have easy access, patients can have easy access to the programs. But you get out into the rural areas, and I'll give you an example. In Nebraska, we have 3 child psychiatrists that are west of Lincoln for the next 300 miles by 200 miles. And telepsychiatry is really the only effective way for them to get access.
One other thing I'll quickly add, CMS has also made some strides in cross-state licensing to facilitate telemedicine. By that I mean is there's a term called compact states. So you live in a compact state, you could live in Arizona, but provide service in Indiana. To get Indiana license becomes much more expeditious on the telemedicine route, and you get reimbursed for that as well. So there are a number of incentives in place. I think there's a outcry, and understandably so, of lack of specialty services. And to your point, I think from telepsychiatry we can bring in subspecialists, may that be forensic docs seeing an inmate, or child adolescent psychiatrist seeing a child adolescent sitting in an ER. So it becomes a lot more flexible, malleable way to provide services.
So these really are, like we see on the med-surg side of the equation, physician extenders, so to speak. One of the other areas that is really increasing and growing in the behavioral health arena is the use of peer-to-peer, peer specialists. I know, Patty, your group has been actively engaged in that. Can you share with us how you utilize peers and what their role is in expanding access?
Absolutely. We looked at the use of peers probably in the late 1990s, and having, during direct services, having peers directly involved, people with lived experience directly involved in supporting and providing services. And what we realized very quickly is that that was a great key to transformation. And so we took it a step further than having peers in direct services, and I think by 2003 we had a peer in our executive level of our organization. And we continue to keep that framework. I think in California today, although we don't have peer certification allowing for peer direct services, we do have a variety of a pilot project in California. It's 3 years old with peer certification. And as an organization, we have more peers certified to the number of clients who we serve than any other organization in the state of California. We have peers at every level. We recruit physicians with lived experience. We recruit people who come in and are willing to use their lived experience as a vehicle to lower the barriers to access and also to provide a model of success and resilience. And so for us, it's been very transformational. The other thing that occurred, which is probably the thing people don't want to talk about in behavioral health, but is really coercive treatment in behavioral health. The sort of no force first model is there. Having peers in the workforce dramatically move the needle in that as well. When you have peers doing the services, you find that you no longer have a need for seclusion or restraint and seclusion. And what you'll also find is you'll find a reduction in your workers' comp. You'll find a lot of other cost savings that are significant, as well as incredible satisfaction outcomes that are improved.
Are you finding that that is applicable both on the behavioral side and the substance use side as well, or one side more effective than the other?
Oh, good question. So on the substance use side, it's been it's been used for a much more longer period of time, so we've got more evidence of effectiveness. But on the behavioral health side, we've seen dramatic changes because it was taboo. Because when people, got their LCSW 20 years ago, you weren't allowed to share your story. And today you're encouraged and taught how to and when to. So I'd say it's both sides. It's really gained momentum.
Well, I haven't had a chance to delve into it yet, but GAO just released a study earlier this week on the use of peer services, what the states are doing, how they're licensing them. I suspect it's much like the Medicaid program. Once you've seen one, you've seen one. So we'll look into that further. But
let me just quickly add to this, which again, another part of telepsychiatry, telemedicine, with CSUs, the crisis stabilization units, and what we call, their psychiatric urgent care essentially, we can now provide oversight by the telepsychiatrist while the patient can be seen by a nurse practitioner or a PA. So that really also makes a big difference now in able to expand service line for oversight.
Great. May I add something too?
sure.
Great. So as part of our Aspire program that I mentioned earlier, we're piloting a digital outreach program for young people at risk for psychosis. It's called Strong 365. It's a campaign focused currently in New York, but it has potential, and we hope to expand it soon to other areas like California or Texas. But what it does, it serves youth who search online for terms related to psychosis, like I'm hearing voices, digital Google ads that direct them to take a screen, like a survey, to see whether they're at risk for psychosis, and if they are, they can connect to care. But unfortunately, it's been challenging to actually get people to connect to care from an online platform. So we're launching phase 3 of this program this year, and this will bring in a peer chat function so that young people can connect to a peer online to chat with them about what they're experiencing and how there might be help for them through care, and also how we're also going to pilot a telehealth component where there can be an actual full-on evaluation done online if they do screen positive with the initial PQB survey. So that would take out one step in between the online contact and then actually getting to care. We hope this will help a lot more young people get to care before their psychosis gets too developed and too chronic.
Pat, anything you wanted to add on that? Good, okay. One of the things that I think is we find across systems that are leading change within the behavioral healthcare arena, they have one unique aspect in common, and that is that they do not treat mental health services separately. They really work towards integration and coordination of those services, and we're seeing a lot of new collaborative models out there. And Patty, I think your group has been actively engaged in doing this for years. Can you share with us some of the things that you've been doing, the groups you've been collaborating with, why they came to the table, and what they're bringing to the table, frankly?
Absolutely. So by the nature of providing community mental health services in the community, it means collaboration. So I'd say that organizationally we've been collaborating for decades. In the past, well, probably with the ACA, more than anything else, we have seen the number of people requiring services and now having funding for services has increased so significantly that there aren't enough services, providers, and funders for these in a way that actually allows the services to be delivered. So one of the examples most recently was in the city of San Francisco, where there was a tremendous need for homeless programs and really and truly an opportunity for people to have extended care. So rather than repeated visits to the EDs and short length of hospitalizations, they really were looking for programs that could be a little bit longer, maybe 3 to 6 months. And we used our services in other communities. 3 years ago, we started the conversation of could this happen in San Francisco? And there were several barriers that were there. And so we got together with a group of partners, the city of San Francisco, the county of San Francisco, UCSF became a prime partner, and then we looked for other healthcare partners. And so through this partnership, we found a location for a program, which was on the 5th floor of an acute care med-surg hospital in San Francisco. We found, but it was a floor that was empty and it was just being used for training purposes. It was in the Dignity Healthcare Hospital. And we together created this partnership where we all partners, Crestwood is one of them, and UCSF, the city, county, and Dignity funded the TIs to bring that 5th floor to be a mental health residential program. And it was quite a transformation, considering that it was a med-surg hospital. And we actually made it, truly, it's a CARP accredited residential program. People can be there for 3 to 6 months. We took about 2 years to create the funding stream and about another year to get the work done. And we opened last April, and our 6-month outcomes were pretty phenomenal. In 6 months, a 54-bed unit served 60 people, discharged 20% to a lower level of care, have had 0 recidivism. It's just 6 months, but it's a start. And we also have an employment program that we use, and we've been able to employ 12% of the people who we've served. So for a community, and we only do that through that group, and UCSF is supporting it ongoing. We have other healthcare providers who are looking supporting it as well. This was quite a collaboration.
Can you talk a little bit about the payment model that you're utilizing, or how that works within that collaborative program?
So it's
Both the funding side and the payment side.
Okay, perfect. So the funding of the actual work, we actually, it was the late mayor of San Francisco who wanted this project. And so the San Francisco came up, I want to say maybe $5 million for the initial services provided. UCSF came up with, and literally just put $1 million into the infrastructure, and then a second, are there with a second $1 million as needed. And then it's, basically, it's realignment funds that are ongoing funding, but we've been able to look at Department of Rehab funding the employment and those other elements, and other Dignity also supported the TIs as well as Crestwood to create the program.
I just want to add, Align, typically the model is to work with more enterprise-level hospital systems. For example, Dignity Health is a key partner for us. Recently, we won the RFP with Christus Healthcare, Adventist. And one of the push from them has been not just providing the ED telephonic services, but now moving it on to ambulatory care and primary care model. And I think that is key. I think as we treat mental illness or we treat physical illness, they both go hand in hand. So being able to address that in a primary care setting where the patient does not have to go to another clinic, another appointment to see, has been immensely successful. So we have now telemedicine modules in the primary care doc offices where certain days allocated for a psychiatrist or therapist to be able to see them on site. And so that's key. So that's part of the whole integration model, primary care integration. That's been a whole huge push. A lot of the health plans, ACOs are at risk now to be able to provide the mental health services as well.
So I would look at this a slightly different way, and I'm going to look at it from just the children and adolescent population of this country. Approximately 10 to 14% of the kids that we get into our programs, and I'm hearing the same from other inpatients and PRTFs around the country, is there are children with serious physical health issues and non-compliance, diabetes, asthma. We've had children with organ transplants that don't want to take all the medications that they need to have on a daily basis. Things that burn victims who don't want to go through that painful physical rehab process every day where you have to really pump them up to say, this is good for you. You've got to go through this pain to get better. So, but there are models out there that are working, but there's still silos out there where you'll have pediatricians who will say, I want to take care of the physical health, and then there's psychiatrists that says, I don't want to have anything to do with the physical health. But we're starting to see that barrier breaking down because people are starting to understand that the interrelationship and the costs that are incurred when you have non-compliance for treatment. The second issue is that mental health is traditionally looked at, and the providers have traditionally looked at their success from the perspective of their program, what they are doing at this point in time, whether it's inpatient, PRTF, outpatient, partial hospitalization. They measured on the treatment effectiveness of accomplishing treatment goals at the end of each episode. The problem with that is that the rest of the world has for instance, Shawn had a shoulder replacement, and he had a whole team of people that worked with him. It was just not the physician and just not the inpatient. He had physical therapy, possibly occupational therapy. There was people that helped him with pain management, et cetera, et cetera. It was a big team approach. And we don't have that in children's mental health developed to the degree that it needs to be. We need to see, and I'll tell you, one of the managed care companies a couple years ago, I'm trying to figure out, where did this start? Their belief is that 7 days after an inpatient hospitalization or a PRTF, that patient must be seen by an outpatient mental health professional, and in order to be effective. And there's some common sense things that we could think about that make sense for that, but the 7-day rule is really kind of a difficult rule to enforce because of the lack of available providers. But this idea of looking at this, just like your shoulder surgery, looking at a hospitalization or a PRTF stay as just one part of the mental health treatment, and the professionals need to work through that whole course of that treatment. Give you a real simple example. Most states have a rule that you have to have a discharge summary done within 30 days. Well, if you're going to go from an inpatient to a PRTF, go to an outpatient setting, and the expectation is that you as a clinician see that patient in 7 days, don't you think you ought to have the discharge summary in hand? What is artificial about it? And so I think it's going to cause us to change how we look at the world, and for the better.
It's interesting, as the more that we know about mental health, the more we realize that it has implications on the physical health side of the equation. Yeah. Most individuals that have a substance use disorder have a diagnosed, or more likely an undiagnosed, mental health issue. Most individuals who have a behavioral health issue have comorbidities. If you're depressed, you don't want to take your diabetes, you don't want to track your insulin, you don't want to follow up with your other types of care. And without that cross-sector coordination and integration of services, you're addressing a problem on one side of the equation, and the physical side of the equation may have no idea that you're suffering on the other side there. So you spoke a little bit about continuity of care. I think that really does get to that issue of who's talking to who when you show up with the shoulder surgery and then I get depressed because I can't golf any longer. Who's going to talk to me about that if I don't raise the issue, et cetera.
That brings to mind another challenge with brain health care in general, which is that if somebody has a serious psychiatric illness, they may be going to see a psychiatrist to get medication, or a psychiatric nurse practitioner, and they may be seeing a therapist as well. But so often they don't talk to each other, or can't share information with each other, and they can't share it with the families who are involved in taking care of the person who is sick. Which is why I'm such a proponent of coordinated specialty care, which I was describing earlier. It's a 5-pronged treatment model which involves a whole team caring for each individual patient, coordinated by a caseworker. So it involves medication, if needed, delivered by a psychiatrist. It involves individual psychotherapy, like cognitive behavioral therapy for psychosis, delivered by a licensed clinical social worker or other type of therapist. It involves family-focused therapy, which is really cool because it involves the whole family together and helping the young person resolve their issues around stress and issues of having relationships in their school and work. And it has supported education and employment to get young people back on their feet in a smooth and stable way. And all this is coordinated together, and that's why it's such a brilliant model, I think. And it's actually shown that it reduces symptoms twice as fast as standard care, and improves quality of life 3 times as fast as standard care at a cost-effective way.
One of the areas we tend to neglect is the care for elderly in a lot of ways. And being a geriatrician myself, I need a transition of care from acute hospital to nursing home back to the ED, and they keep shuffling back and forth. And you see a lot, especially when you're taking care of patients with dementia-related behavioral disturbances, and so on. And unfortunately, they don't meet the acute hospital admission criteria. They don't have a geropsych unit to go to in the hospital. So they get treated there with strong medication, then a psychotics and whatnot, and get sent back. So one of the things we're doing now is called continuum of care, where we're offering follow-up services in the post-acute, so we can stop the bounce back, because that is profoundly detrimental for seniors already going through a lot with dementia-related delirium or acute confusion, and then to be bounced back and forth. So a lot of the telehealth can also is providing services as a continuum of care to the post-acute space as well.
Well, I wanted to end this panel discussion with the notion of alternative payment models within the behavioral health arena. And we know that there's been a big push by CMS to move forward to value-based purchasing. You're probably all familiar with some of the targets that CMS set several years ago of having 60–80% of services provided are paid for under a value-based system. Unfortunately, that does not really exist on the behavioral health side of the equation. There's not a lot of work that has been done in trying to figure out how do we develop alternative payment models for a system that, frankly, I think has been underpaid for years and undervalued. But I just do want to end, and I did mention earlier the IMD exclusion that was enacted just recently as part of the Support for Patients and Communities Act. That is really based on some early data that's happening out in the field today under Section 1115 waivers under the Medicaid program, which is really, you could argue, a value-based purchasing model in that states are required to basically make dramatic changes within a budget-neutral manner. Don't spend any more money than you would have otherwise spent within the system. And Virginia, the state of Virginia, has moved forward with an initiative, and some of their early findings are that by utilizing and providing behavioral health services within these formerly excluded IMDs, that they have seen a dramatic reduction in the amount of opioid-related emergency interventions. They've seen a reduction in that of almost 39% in the first year. And they've also seen a 31% reduction in the amount of readmissions for those same types of services under that period. So it's a system where, unfortunately, there's not a lot of alternative payment methodologies out there, but people are beginning to think about it, and we are seeing some practical evidence on the ground out there today that by investing in these services, in the behavioral health side of the equation, that we are seeing returns on the physical side of the equation. So I think that rounds out our discussion pretty well today, I hope. So any other issues that any of the panelists would like to raise, or otherwise we'll open it up to conversation and questions from anyone in the audience. I know we're standing between you and the big ticket discussion that's coming up here, so.
Hello. You can hear me? Okay. Just to give you a background to my question, we come from a hospital that's on the northern tip of Los Angeles County, but we serve patients from 4 different counties. Our emergency department was built to see 30,000 a year, but we see 145,000 a year. We have 22 monitored beds, but we see 450 patients a day. So with that, and a little less than 3/4 of our patients that come through the ER are either uninsured or underinsured. And this is it's a telepsych question. One of the things we run into is with the short amount of staff that we have and the short amount of beds that we have compared to the amount of patients that come in, one thing we run into is a lot of our psych patients are automatically 5150s. Some probably should stay 5150s. Most of them, they could probably be rescinded. We tried telepsych before. The problem was that every physician we had through telepsych either put someone who was not on a 5150 on a psych hold. If they were already on a psych hold, they would not rescind the hold. So recently, and this is even without telepsych, recently we had 17 holds. And again, we're only 22 monitored beds with other beds that are not monitored. But we're in California, so we have the 4-to-1 nursing ratio law. So that takes 4 nurses completely away from just medical care. Do you collect data on, out of curiosity, if your telepsych physicians, are they willing to rescind holds? Do they feel comfortable doing that because they're not face-to-face with the patient?
Excellent question. I know Rod Shaner well, so I have data with him as well in the LA County and Dr. Sharon. So yes, we collect data. The reason Aligned has had success, we have a very strict quality control within. So we have a VPMA dedicated to looking at holes that was initiated or discharged. We're looking at e-holes now as well. The reason that's important is because I don't think a hospital wants to partner with a group that's going to just keep putting more patients on hold and board them in the ED. So our goal really is if they come in on a hold, we see them on a Q4-hour basis while they are in the ED to clear them and discharge them. And so again, it really boils down to partnership. But to answer your question, we maintain a complete, not only quality metric, but data on when they were seen, were they put on hold or not, what are the medication dispensed, polypharmacy restraints, and how many of them were let go from the ED. And our data currently suggests that since we have come in for telepsych, we've been able to discharge a lot more than that being transferred prior to us coming in.
I want to answer that question in a slightly different way. We have a fundamental problem in this country is we have a shortage of inpatient beds. And so as a result, what happens is the emergency rooms, and we have a shortage of mental health professionals. So our emergency rooms are sometimes, people will say they're clogged up with mental health patients at the same time that they're trying to serve trauma patients, and et cetera. So they get moved from the emergency room, they get in the holding beds, and then they get put into inpatient beds in their hospital or in some other hospital. The inpatient program focus has now become crisis stabilization. So you're to solve this sometimes very complex problem in 2 to 3 days, and then you're to send them out into an outpatient world. And there's a shortage in the outpatient world, so there may be a gap between the time they get discharged from the inpatient to getting the outpatient service. And what often happens is they're back in the emergency room, and the cycle repeats itself. And we've seen kids that have failed 7, 8 times. They've gone to the emergency room 7, 8 times before they get sent to a higher level of care, because the focus is on movement, because there's a shortage of bed and it limits the access.
That's true. I think in AD, typically 34% any given time of the patient that come in are with chronic mental illness.
My question is for the entire panel. From your perspective, what do you think that is the major factor for the psychiatrist shortage? So that's one question. And the second one will be, as providers, do you think that is kind of related to the school system, and can we advocate to make a change?
I can take that. From what I understand is we have a huge retiring population of psychiatrists. I think there are about 37% who are in the late 60s now. So there's going to be a huge shortage coming in the next 2 years. So big watershed. It is not the most attractive specialty for a lot of the nuanced docs to graduates to get into. It's psychiatry still. And a lot of people don't want to go into the therapy-based programs. So I think that's probably where it is. And also there's a shortage of overall residency program itself and incentives for the medical students to go into the specialty of psychiatry.
Also, so psychiatry tends to be reimbursed at a lower rate than physical health care. And so psychiatrists have to, I've learned this from my psychiatrist, they often have to battle with insurance providers to get adequate reimbursement to maintain their practices. So my current psychiatrist does not work with insurance companies, at least not my insurance company. I need to work directly with my insurance company. He's out of network. That makes it harder for psychiatrists to maintain their practices, which makes it less attractive as a profession.
Great point. And I think that is what is making telepsychiatry very attractive to them, because they can work from their home office. They can be where they are, logistics out of the picture, but they can have significant ad reimbursement or revenue from telepsych interaction. So you're absolutely right. Yeah.
So I was trained in neuropharmacology. In the last several years, I led a project for the United States Air Force on how to document the impact of integrative medicine. And one of the things that I learned is the concept of behavioral health is really flawed. because it doesn't really come out of the brain, it comes out of the gut. And the question really is I didn't hear anybody talk about the gut biome, how the gut biome is maintained to be healthy. And because when I was trained, I never even heard of an enteric nervous system. And there are herbal treatments that are far more effective than any antidepressant out in the marketplace. So I want to know, in your organizations, what are you doing about gut health with the people that you serve? And what do you look for in the future with regards to moving in that direction?
So we've actually funded a scientist named Scott Russo, who was intending, or I believe he may have already started to work on that, investigate that area. He's working on inflammation and how that turns into depression. And when the gut has an unhealthy microbiome, it can lead to inflammation throughout the body, including the brain. So that it clearly does affect people's brain health, as you said. We're interested we are funding a scientist who I believe is working on that.
So this is not a new phenomenon, right? You
Right.
need to be in touch with people from the Institute for Functional Medicine because it's an astounding amount of data. So for example, curcuminoids will reduce the inflammation in the gut, and that is one of the key components for inflammation that generates, that's associated, should I say, with decay under Alzheimer's. So is the production of interleukin-6. So there's an extraordinarily rich arena there that if we have to wait for the next 17 years for clinical medicine to catch up, we're going to have a very long. This is a disruption conference, right? Did I forget that? So please, please, please focus your efforts on that area, because that is really, these are not separate phenomena. When we organized a payment system as though they were, and they are not.
Thank you.
We did some work with UC Davis, and again, this is more from the practical side of providing us services, but it was looking at the impact of changing a person's wellness routines, specifically diet and metabolic systems, in looking at the behavior changes. And although it's just the beginning of a study, we're still part of that study going on now.
It's a very interesting point as the notion of social determinants of health creeps into the discussion. Only about 20% of a person's overall health is impacted by intervention by the medical community, regardless of whether it's behavioral or physical side. That 80% of their wellness is associated with where they live, how they eat, a whole wide variety of other initiatives, and it is something that is increasingly coming into the discussion.
It is, yep.